Hello, my name is Shibal and I'm going to talk to you today about dry eye and glaucoma. Ocular surface diseases seem to be the running pandemic across the globe. Studies over the course of time have said that the incidence of dry eye amongst the general elderly population ranges from 15 to 50%, while the prevalence of OSD in glaucoma patients has been documented as more than almost 70%. What we have seen in clinical practice is that almost two-thirds of our glaucoma patients have some form of ocular surface disease or the other, and which is why eye and glaucoma constitute double the trouble. The frequency of both ocular surface diseases and glaucoma increase with age, so they are common comorbidities. The increment of OSD with an increase of glaucoma severity is also something we know about. As glaucoma severity increases, the number of drops increases, the preservative load increases. And because advanced glaucoma patients tend to be on multiple drops, with a longer duration of treatment and consequently preservative and drug exposure, there is lower quality of life from both ocular surface disease as well as the decreasing visual fields. 40% of glaucoma patients require more than one IOP lowering drop daily. 1 in 6 patients with glaucoma have ocular surface disease symptoms that are severe enough that they need some form of treatment. 15% of patients above 65 years of age anyway require some form of treatment for dry eyes. Almost 40 to 60% of patients with glaucoma above the age of 65 years require some form of dry eye interventions. It's very important to remember how quality of life is impacted by both dry eye and glaucoma as far as the physical quality of life related to vision is considered. Conventional wisdom said that the decrease in quality of life as glaucoma progressed happened as the visual field loss increased. However, we now know that the initiation of glaucoma therapy per se has a decrease in quality of life of the patient. And this decrease is significantly more than what was conventionally thought. This is especially true because of the additive effects of the preservatives and the drugs themselves on the ocular surface. Any dryness of the eye with symptoms of irritation, redness, subconjunctival hemorrhages with the newer drugs, as well as irritation because of allergies, and the consequent redness of the eyes and watering, lacrimation, and the impact on vision per se, all of them have a significant effect on the quality of life of the glaucoma patient. And this is the real-time disease progression and passage of time curve. If you will see, the diagnosis of glaucoma per se is causing a decrease in the quality of life of the patient. And as treatment is initiated, the quality of life is much more than presumed otherwise. Also, dry eyes affect visual fields as well. The reliability of visual field measurements are impacted directly by dry eyes. The use of artificial tears is known to decrease the visual field testing time and also improve the test results. In fact, the use of artificial tears seems to improve significantly both the reliability parameters and the visual field indices in glaucoma patients. This is another case that I thought would be very interesting to highlight how dry eyes can also affect RNFL imaging. This is a patient of mine who was somewhat stable. This is a juvenile open-angle glaucoma over time. And suddenly I wasn't paying much attention. And I was like, oh my God, what happened? That's a severe loss of RNFL thickness. And only then did I see this black spot here on the RNFL OCT. Of course, this was because of dryness of the cornea. The RNFL wasn't imaged properly. And then when we repeated after putting in a drop of artificial tears, there he is with the same RNFL thickness as 1 year ago, which is why it is extremely important that you be very cognizant of dry eyes in patients of glaucoma. Remember, BAK impacts goblet cells, and this is a significant dose-dependent and duration-dependent loss of goblet cells, which means the number of drops, the duration for which the patient is on drops, and the number of drops that the patient uses every day, all of them have a significant impact on the goblet cells in the eyes. Similarly, all glaucoma medicines also result in goblet cell loss. Preservative-free lubricants, when they added, do not cause a significant loss, but any medication, regardless of what is the preservative, there is a significant decrease in the goblet cell count. BAK is also known to impact the corneal epithelium and is neurotoxic. BAK-treated corneas exhibit significantly reduced nerve fiber density and aqueous tear production and increased inflammatory cell infiltration and fluorescein staining, even for as short a duration as 1 week. BAK is also known to impact the trabecular meshwork, and this is Boudoir's classic work. BAK enhances all characteristics of trabecular meshwork degeneration typical of glaucoma. This includes trabecular apoptosis, oxidative stress, induction of inflammatory chemokines, and causes degeneration of the trabecular meshwork. Acute experimental conditions potentially mimic long-term accumulation of BAK into the trabecular cells. BAK can access the trabecular meshwork after repeated installations is something we know for all our glaucoma patients. We also know that glaucoma medicines, ocular surface diseases, both have a significant impact on surgical outcomes. Preoperative subclinical conjunctival inflammation induced by previous topical medication is identified as a risk factor for failure of trabeculectomy. Understandably, so many of us actually stop anti-glaucoma medications, topical ones for some time, and often use low-dose, mild steroids so that we might have lesser inflammation on the ocular surface before taking up the patient for surgery. And this is known to significantly impact how your filter progresses and works over time. Preservative exposure is also something that impacts surgical outcomes, and this is something that we forget all the time. The time to surgical failure in patients who receive higher preoperative daily doses of BAK is shorter, significantly shorter, as you will see from the first Kaplan-Meier survival curve. Increased preoperative exposure to ophthalmic solutions preserved with BAK is therefore a risk factor that is independent of drug use for early surgical failure, and it is also independent of the number of medications used, as you will see in the second graph here, the second Kaplan-Meier survival curve. So what we have to remember then is that not only is it the number of medications that we are using, but also the number of drops per day, as also the number of preservatives that we are using, as also the duration of medication. All of them independently will have an effect even on your surgeries. So we have two independent variables here, the number of drops, the preservative used, and the duration of medication, all three of them impacting two independent variables. One is the quality of life of the patient if the patient is treated alone on medication, and two, the outcome of the surgeries that you do in case of medical failure. So remember, very often we are tempted to offer early surgeries to the patient when they are not able to tolerate the medical therapy because we say, oh, this patient is unable to use medicines because of the side effects. Let's look at an earlier surgical intervention. Remember, these patients have a higher risk of surgical failure also. It just might then be a sensible option to stop the medication for a little while, transfer the patient to an oral anti-glaucoma medication, heal the ocular surface, maybe with a low-dose steroid, in the interim while you plan for surgery. That is also something that a lot of us choose to do before performing trabeculectomy, which is why it's important to remember that the preoperative conjunctiva is a great predictor of trabecular success after a trabeculectomy. The reservoir for fibroblast recruitment at the site of filtration surgery are the inflammatory cytokines. And 356 months of treatment means that there is an accumulation of T lymphocytes and fibroblasts in this particular cell, in this particular patient. If you can see the second one, you can see how badly inflamed this particular conjunctiva is. And thereafter, after stopping anti-glaucoma medication, this patient was put on steroids, and you can see how the inflammation and how the immunoperoxidase T lymphocytes and fibroblasts have reduced in concentration. Obviously, the surgical success, therefore, is going to be much, much more in this patient. We will just go over preservatives and glaucoma medications the one time. Most of the available medications are preserved with BAK, and their usual and the most commonly used percentages of BAK are written here. Travoprost is available as the innovator molecule in a polyquad form, Sobzia outside of the country. Bimatoprost, latanoprost, uniprostone, timolol, dorzolamide, brinzolamide, brimonidine, pilocarpine, all of them are BAK preserved. Of these, bimatoprost is available in two concentrations of the drug per se. The bimatoprost 0.01% has a higher concentration of BAK than 0.03%, which is the drug with a lower concentration of the drug per se. Again, Remember, it's both the drug and the BAK, which are both impacting the quality of life of patients as far as the ocular surface is concerned, as well as the surgical success post-trabeculectomy is concerned. Let's go over quickly the preservative characteristics and the cell effects of each of these. BAK denatures proteins, purite oxidizes unsaturated lipids and glutathione. On the tear film back is a detergent, and then it also affects the precorneal film stability. Sofzia causes increased evaporation and decreased TBUT. Purite is better. Polyquad causes excessive tear evaporation. The first three affect the corneal epithelium. BAK is also cytotoxic and is also affecting the trabecular meshwork. The others have not been studied for as far as the TM is concerned. Sofzia also causes disruption and loss of organelles and epithelial cell dysfunction. Purite also causes epithelial corneal damage and minimal loss of microvilli, while BAK causes disruption and loss of organelles as well as epithelial cell dysfunction. Again, there is no preservative that is good for the eye. Just remember that. I think that's critical to remember. Just as you would remember in your food, preserved food is something which is not good on your table. You must, as you would choose fresh organic produce, you should look at preservative-free drops for the eyes. And which just brings us to a very, very unique configuration of fixed drug combinations, which are like a panacea if you're looking at dry eye and glaucoma. Potential benefits of fixed drug combinations, of course, are the additive efficacy, the decreased preservative exposure, the better tolerability, the decrease in dosing frequency, consequently adherence, and also loss of washout. The inherent advantages, of course, are very, very clear. There are fewer drops to instill. There's a single bottle for multiple drugs. It is definitely a less complex regimen, better compliance and adherence because it's a less complex regimen, and there is no washout because both drugs are being put into the eye simultaneously. Of course, you need to be very, very cognizant that both the drugs, if you use two drugs at the same time concomitantly and the patient develops an allergy, you will not know which drug allergy the patient is suffering from, and you'll have to take the patient away from both drugs. So the best way to look at FDCs, fixed drug combinations, is to use one drug at a time. So you can do both safety and efficacy analyses for both the drugs separately before initiating the patient on an FDC. Therefore, if you're looking at, let's say, a bimatoprost-timolol combination, first check the efficacy and safety of timolol or bimatoprost, and then the other drug, and then you can give it as an FDC. Now, so then what defines maximal medical therapy? Preservative exposure is a very, very important thing to remember. The cost of treatment, the compliance of treatment. There is a higher risk of local as well as systemic side effects, allergic reactions, as well as toxicity from the active ingredients, inactive ingredients in the drug formulation, as well as the preservative per se. And you must make sure that the drugs that you put in a bottle are always drugs with different mechanisms of action. Remember, there are two things that are critical to management of glaucoma. One is the quality of life of the patient, which actually determines your target eye pressure. So now what we're working within is more optimal medical therapy than maximum medical therapy, where the determination of whether medical therapy is good for the patient or not does not depend on the number of bottles or the number of medications, but it depends on individualizing the glaucoma treatment to what that particular patient needs. And as we step into the era of personalized, customized medical care, optimal medical therapy is the way to think. Glaucoma treatment needs to be individualized. For a young patient, perhaps having 4 bottles or even 3 bottles is a long time because that's 30 minutes of instillation twice a day. And that's usually something that somebody with a busy lifestyle will struggle with. And which is why compliance and adherence will become a serious concern. Less exposure to preservatives is what we must strive for. Look for preservative-free formulations when you can, and as few bottles as you can think of. Think of less washout effects because finding half an hour in the morning and half an hour in the evening again to do 3 bottles is not going to be the simplest for anybody. The cost of therapy, of course, we must look at cost of therapy in the economic cost of therapy, as well as the quality of life cost of therapy. And we must look at surgical alternatives faster and better when we are looking at optimal medical therapy. When you need more than one drug, and when you're going to put it in one bottle in terms of a fixed drug combination, Remember to make sure that each individual drug being used concurrently is effective. That is, both drugs should be used before and be evaluated for their impact on eye pressure before a fixed drug combination is given. And consequently, you will also be doing a safety analysis for each drug sequentially so that you know that the patient is not allergic to either medication. At the end of this, let's keep it really brief and really succinct in remembering what we must do for our glaucoma patients. Remember, ocular surface diseases are higher in glaucoma. Remember, ocular surface diseases are associated and worsened with glaucoma therapy and preservative exposure. Remember that ocular surface diseases are associated with decreased quality of life scores, just like deterioration of visual fields. Ocular surface diseases and drop uses is associated with reduced surgical success. This also includes preservative load. Fixed dose combinations decrease the preservative exposure. Always prefer back-feed drops or those with minimal preservatives. Look for the least amount of preservative in your drops. Remember to prescribe lubricants. Remember to tell your patients to use them after using your anti-glaucoma drops. Remember that your patients will remember to use the lubricants and will forget the glaucoma drops because the lubricants make them feel better. And as I always say, whenever you're treating a patient with glaucoma, remember Lord Hutchison's prayer. From inability to let well alone, from too much zeal for the new and contempt for what is old, for putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. Remember, a glaucoma patient is often asymptomatic till you start glaucoma therapy. And that puts the onus of taking care of them squarely on your shoulders and mine. I hope this has been of some use to you in your clinical practice. Thank you so much for your attention.